This
the most
conference will now be
efficient, the
recorded.
most merciful. Assalamu alaikum and good morning, everyone. I am Dr. Sadia Imtiaz, Senior Registrar and the Fellow of Orbit and Oculoplastics at IUNA 3 Mayo Hospital. I am highly privileged to welcome you all on this auspicious occasion of monthly OSP clinical meeting at Institute of Ophthalmology, Mayo Hospital. For an official welcoming address, I would like to invite our very beloved and honorable Dr. Nasir Chaudhry, who is currently working as Associate Professor at IUNET 2 Mayo Hospital, to join the podium and welcome our respectable audience on behalf of Institute of Ophthalmology.
Bismillahirrahmanirrahim. This is indeed great pleasure to be here on behalf of Chairman Department of Ophthalmology and Department of Ophthalmology. I would like to extend my deep gratitude to honorable and worthy office bearers of OSP Lahore, uh, President Professor Dr. Moeen, Dr. Hakan, General Secretary OSP Lahore, but he is not here because of his personal commitment. Professor Dr. Mumtaz, Professor Dr. Intizar Bhatt Sahab, Professor Dr. Raza Ali Shah Sahab, and prestigious gathering from different institutions of Lahore. OSP Lahore has a huge role in uplifting academics across the country through its time to time scientific sessions in the form of instruction courses and symposia, routinely conducted annual ophthalmology conference, a big scientific session, and then routinely conducted this monthly clinical meeting. अगर हम इस क्लिनिकल मीटिंग की इम्पोर्टेंस को देखें तो वी विल रियलाइज कि ये क्लिनिकल मीटिंग जहाँ पे रेजिडेंट्स की जो क्लिनिकल स्किल है नॉलेज एटीट्यूड को रिफाइन करने के लिए इनकी क्लिनिकल अप्रोचेस को बेहतर करने के लिए इनकी एम्पैथी टुवर्ड्स द पेशेंट पेशेंट सेफ्टी प्रोफेशनलिज्म और इनके लिए जो इंस्पिरेशन एंड मोटिवेशन टू बी एन compassionate and competent ophthalmologist वो एक रेजिडेंट के एक्सपेक्ट अगर आप देखें तो चीज़ें बेहतर होती हैं ऑन दी अदर हैंड अगर आप रियलाइज करें तो ये हम जैसे हमारी जो टीचिंग फैकल्टी है उसके लिए भी दिस इज वन ऑफ द ग्रेटेस्ट सोर्स ऑफ कंटिन्यूस प्रोफेशनल डेवलपमेंट और कंटिन्यूस मेडिकल एजुकेशन सो ये क्लिनिकल मीटिंग और ओएसपी लाहौर के जितने भी एकेडमिक्स प्रोग्राम हैं ये मल्टी फैक्टोरियल होते हैं यहाँ पे ये रेजिडेंट्स की स्किल्स को इन्हांस करते हैं फैकल्टी के लिए सोर्स ऑफ कंटिन्यूस प्रोफेशनल डेवलपमेंट एंड द पीपल हु आर वर्किंग एट डिस्ट्रिक्ट लेवल एंड तहसील लेवल उनको भी मौका मिलता है कि वो अपनी जो मेडिकल प्रैक्टिस को ऑप्थेल्मिक प्रैक्टिस को करंट प्रैक्टिस के साथ अलाइन कर सकें तो सो इन्हीं अल्फाज के साथ आई वुड लाइक टू वार्मली वेलकम ऑल द honorable guests and prestigious gathering from different institutions. Thank you.
Thank you so much, sir, for such an elaborative welcoming address and your precious words. Without further ado, let's begin the ceremony in the name of Allah, the most gracious, the most merciful. I would request Hafiz Maqsood Sahab to kindly join the podium and recite few verses from Holy Quran.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم والتين والزيتون والزيتون وطور سينين وهذا البلد الأمين. لقد خلقنا الإنسان في أحسن تقويم. ثم رددناه أسفل سافلين. إلا الذين آمنوا وعملوا الصالحات فلهم أجر غير ممنون. فما يكذبك بعد بالدين، أليس الله بأحكم الحاكمين. آمنت بالله، صدق الله العظيم، وبلغنا رسوله النبي الكريم.
Jazakallah. May Allah bless you and enhance you in the beauty of your recitation. खुदा का जिक्र करे जिक्र मुस्तफ़ा ना करे, खुदा का जिक्र करे जिक्र मुस्तफ़ा ना करे, हमारे मुंह में हो ऐसी जुबां खुदा ना करे. For this great purpose, I would like to request our very beloved and honorable Professor Dr. Raza Ali Shah, Head of Department of Eye Unit 2, Mayo Hospital, to kindly join the podium and let us spiritually enjoy with your magical voice while praising our Holy Prophet, peace be upon him.
Thank you very much. Sallu ala Muhammadin wa ali Muhammad. हजूर ऐसा कोई इंतजाम हो जाए, हजूर ऐसा कोई इंतजाम हो मैं सिर्फ देख लूं एक बार सुबह तैबा को, बला से फिर मेरी दुनिया में शाम हो जाए। तजल्लियात से भर लूं मैं अपना कासाए जान, कभी जो उन की गली में कयाम हो जाए। हजूर आप जो सुन लें तो बात बन जाए। हजूर आप जो कह दे तो काम हो जाए। मज़ा तो जब है फरिश्ते ये कब्र में कह दें, सभी है मिदहते खैरुल अनाम हो जाए। हजूर ऐसा कोई इंतजाम हो जाए। सलाम के लिए हाजिर गुलाम हो जाए। दरूद भेजिए मोहम्मद।
Jazakallah, respected sir, your voice and words really created a spell over the audience. Ladies and gentlemen, without any delay, I would like to invite President OSP Lahore, Professor Muhammad Moin, who is currently the Dean of Ophthalmology at Mayo Hospital, Principal of College of Ophthalmology and Allied Vision Sciences, who has been instrumental in the field of ophthalmology. He possesses so and has knack of achievements. As an outstanding speaker, multi-talented ophthalmologist, and of course, a matchless researcher, I would humbly request you to deliver your address on behalf of OSP Lahore.
Assalamu alaikum, everybody. I warmly welcome you to this meeting of the OSP Lahore. I think we started on time. Usually people start joining in. I welcome Professor Mumtaz Hussain. He's been a former department chair over here in ophthalmology. Professor Hamad, he was here with us as well. Thank you very much for coming. I'd like to thank Professor Asad Aslam Khan for his presence and Professor Intezar Bhatt, Professor Raza Ali Shah for his very nicely recited Nath. and Dr. Raza Ali Shah is here. All the rest, seniors, Ali Yaz, I think he's gone for a curriculum meeting over there. We have the PMDC visit is on the 18th and 19th. They're going to check King Edward Medical University regarding, I think, for accreditation initially. This is initial inspection for which probably we might get selected for the WFME visit for accreditation of the university as such. So that is a big honor for us, but we have to prepare, and some of us was working on those lines as well. Sidra is here, Salman is here, Farouk is here, and Dr. Shabana has been working very hard on organizing this meeting, and she was with the residents, getting them prepared for the meeting. But most important is she got us our international talk, which is from Mr. Reddy from United States in London. So that will be an interesting talk on retinoblastoma. OSP has been working over the years. I think this is going to be one of the last clinical meetings. This is October, I think November. Adil hai koi November ke? Nahi hai. So this is the last, I think, tenure mein. Before we change over next year in December, they will be handing over to the new president, President-elect Professor Javed Chaudhry. We're lucky that he's also from King Edward Medical University. He's retired from here. It's been 2 years have been very hard, and it's difficult to organize stuff, but we have achieved major two milestones, that we have been able to conduct two international meetings. One was the Afro-Asian meeting, which was a huge success, and the second one is the Asia Pacific Trauma Society, along with the Lahore Ophthalmo, which is going to be held from 8 to 10 December. And we've got lined up like 40 international speakers which are going to be here. And for the institute, we've talked with Professor Claire Gilbert, and we're trying to arrange an ROP symposium, which is going to be one day before the meeting on the 7th here in COAS Auditorium. And that is going to be the different highlights. We're going to have medical education sessions. We're going to have leadership sessions. Then we've got, I think we've got 18 or 19 sessions on surgical retina and medical retina, and they're going to be spread with a lot of international speakers. The main problem organizing the meeting is meeting registration is like 2,000, 2,500. जो हमने हॉल की कैपेसिटी रखी होती है वो टोटल मिला के शायद 800 या 1000 से सीटिंग कैपेसिटी नहीं होती, लेकिन हॉल खाली होते हैं. माय रिक्वेस्ट इज प्लीज सपोर्ट अस. इट इज योर ओन ओन मीटिंग, और उसको आप सपोर्ट करें एंड बी देयर. आपके विजुअल साइंसेज and the ophthalmic technicians, they are here. You support your meeting. It is you who are going to be there. You learn a lot. इंटरनेशनल फैकल्टी को यहाँ पे बुलाने का मकसद ये है कि you interact with them. जिस तरह हमारे पास we had optometry, they had the international faculty. Nicole, she came from Australia, and she was here to give a lecture. But it's always good that you interact, you see what is happening around the world and how you can improve yourself, because some of you might be going abroad, and some of you, well, optometry as such has got quite horizons internationally as well. Apart from ophthalmology, maybe there are a lot of you who are residents who might want to go internationally, want to do rotations, might want to do ICO workshops. So those are opportunities which you should not miss, and you should attend the meetings. Hall, please, khali na chhodiyega, which is going to be very embarrassing for us. Last year भी ये feedback आती थी कई halls में, there are not people there. आपको यहाँ से अगर कोई क्लास ऑफ देते हैं, अगर हम कहेंगे कि आप फ्राइडे को अगर ऑफ है ऑप्टोमेट्री वाले या बाकी सुबह जाके, तो उसका मतलब ये नहीं है कि वहां जाके घंटा उठ के आ जाना है. तो यू नीड टू, या खाने के लिए जाना है, दो ही ऑप्शन होते हैं पाकिस्तान में, या खाना खा ले उसके बाद सब कुछ खत्म हो गया. एवरीथिंग revolves around that, which obviously it's fair, but इंटरनेशनली अगर मैं अमेरिकन एकेडमी में जाऊंगा तो यू डोंट गेट एनी लंच और एनी डिनर, अपनी जेब से दे के लेना है, तो डजंट मेक अ डिफरेंस. इट्स द नॉलेज व्हिच यू वांट, दैट इज द नॉलेज की hunger is something which is going to be important for you. Okay? So we welcome you. We've got I think 4 presentations, and then Mr. Reddy's talk from UK on retinoblastoma, and then we're going to have a national speaker talk. This time I changed the topic. It's going to be our VC, Professor Mahmood Ayaz, He's going to give a talk on robotic surgery. It is not that we want to learn about intestinal robotic surgery. It's just the idea what is robotic surgery, what its implications it's going to have on ophthalmology. So I request each and every you to not to leave this because you're going to get lunch after this. So don't worry about that. But you need to show here and show your solidarity over the whole session as such. So we've got a very good, interesting presentations lined up. So bear with us. Thank you.
Thank you so much, sir. That was most delightful to have words from you. Before proceeding towards the formal scientific program, I would request few of our esteemed members to kindly join the podium and have their seats. Professor Muhammad Moin, President OSP, Professor Asad Aslam Khan, a Professor of Emeritus and the founder of everything we have there, Professor Razali Shah, Head of Department I Unit 2, Professor Intizar Bhatt, Head of Department I Unit 1, and Professor Mumtaz Hussain, the supervisor of our supervisors and the ex-dean of ophthalmology. Kindly join the podium and have their say. Okay. Okay, our scientific program of monthly OSP clinical meeting will be according to the standards set by OSP. As highlighted by Professor Mohammad Moin, we will be having 4 case presentations by our residents. Each presentation will have a duration of 6 minutes with 2 minutes question and answer session. I am very delighted to announce that we have one national speaker whose talk will be on the robotic surgery and one international speaker who will enlighten us with the knowledge of intravitreal chemotherapy in retinoblastoma patients. Ladies and gentlemen, let's start the formal proceedings. For this, I would request Dr. Shujaur Rahman, fourth year resident from I Unit 3 Mayo Hospital, to kindly present your diagnostically challenging case. Dr. Shujaur Rahman.
Bismillahirrahmanirrahim. We're going to present a very interesting case and a very unique one too, from OT table to the corridors of the pediatrics ward. This is a disclaimer that there are no financial interest and no third-party funding. So we come to a case. The case history of 15 months child presented to us in emergency, fall from bed and he had a history of trauma. He had a fall from bed 15 days back, and then he developed left-sided proptosis, which was gradually increasing in size, and it was associated with fever and pain. On the ocular examination, the visual acuity in the right eye was following and fixating and was unremarkable, but on the left side there was photophobia, and the pupillary light reflexes, left eye was non-reactive. There was afferent pupillary defect noted, and the purulent exudates around the lashes, left-sided ophthalmoplegia, which was associated with the left eye proptosis, and the proptosis was measured by 25 millimeters. It was also associated with the lid edema, conjunctival congestion, and chemosis, and unilateral facial swelling. After ocular examination, we had the systemic examination of the child, and the positive findings in her general physical examination was pallor, tachycardia, fever of 101 degree Fahrenheit, and it was associated with the irritability. There were no palpable lymph nodes regionally like preauricular or cervical, and the rest of her examination was unremarkable. Then we shift our made our differential diagnosis on the basis of preliminary presentation and examination, and At the top, we made the diagnosis of orbital cellulitis, which is a most probably infective, post-traumatic, because of rapid onset pain associated with the fever. The second one was intraorbital bleed, and this intraorbital bleed might have secondary infection due to the trauma. The third one, due to its aggressive behavior, rapid onset, rhabdomyosarcoma. Due to the age of the patient, we had retinoblastoma at the back of our minds. Lymphangioma comes last. It can possible that due to the trauma, intralesional bleed can happen and secondary infection can happen, leading to this picture. Then we had a B scan, and the B scan findings shows hyperechoic amorphous lesion occupying extraconal and intraconal space. A CT scan was advised, and the CT scan showed isodense mass occupying medial extraconal space, indenting eyeball, mass extending into the subcutaneous plane of skin in temporal and cheek area. There are no intralesional bleed found, no calcification found, and the eyeball was pushed forward and laterally. The mass was inseparable from the inferior rectus muscle. On the systemic examination, there was marked white blood cell count raised 25,000. BSR was 90. There was lymphocytosis. There was also neutrophilia, but the lymphocytosis was markedly raised. So it raises suspicion of atypical organism. Then the rest of her examination, including LFTs, RFTs, serum electrolytes, they were in the normal range at that time. In the initial management, we started initial treatment with the IV antibiotics, keeping the orbital cellulitis as our main diagnosis. IV antibiotics, including ceftriaxone and flagyl empirical treatment, proved to be ineffective after 2 days. So, proptosis became worse on palpation. A firm mass was palpable in inferomedial extraconal space. So it was a challenging case. It was diagnostically it was challenging case. So we planned an immediate surgical intervention, and her left orbitotomy was planned and performed on the emergency basis. Firm gray white poorly circumcised infiltrative mass removed surgically and sent for histopathology. So our whole diagnosis was dependent on histopathology report. And what turns out to be? Histopathology shows mucormycosis. It was astonishing for us because the child was not immunocompromised, and the child age, and there was no history of diabetes related thing, but it was mucormycosis. Then we asked the histopathology department to review the report, but the results were consistent with the mucormycosis. An immediate interdepartmental liaison was created, and IV amphotericin B started. After the start of IV amphotericin B, her RBC count decreases to 10,000, and the patient was treated at the PEDS department. This was a picture at the presentation first day. This is a picture after the IV antibiotics third day. This is a picture after amphotericin B and orbitotomy 1 month. And this is the picture of the patient after 2 months. And at present, this is the picture of the patient. So the protocols of amphotericin B, test dose, initial dose, and then a maintenance dose. Warnings for amphotericin B, because it causes a lot of side effects, including it can cause cardiac and cardiopulmonary arrest. There are acute reactions, including fever, shaking, chills, hypotension, and our patient had all these symptoms, all these adverse effects of the drug. And they were managed conservatively using antihistamines and judicious use of corticosteroids. So the point is trauma and mucormycosis. Normally, it happens in immunosuppressed child, but this disease has also been observed in neonates, patients with the burns, and children with the history of trauma. Disease presentation, because the molds are present in organic matter and soil, it can cause direct inoculation after the trauma. The mucormycosis is life-threatening. It is life-threatening infection. It can cause rhinocerebral disease, CNS disease, pulmonary and GI disease, and cutaneous disease. So investigations, as we followed, radiological and histological, And once mucormycosis is suspected, obtaining tissue for culture is vital. Management includes medical management, and the drug of choice is amphotericin B. Surgical debridement, monitoring for the long-term complications like recurrence can happen, and a multidisciplinary approach. Interdepartmental liaison is very important, including endocrinology and oncology for the immunocompetent status. So what's the learning objectives of this presentation? That any immune competent child can develop mucormycosis after orbital trauma and wound contamination. Second, always rule out mucormycosis in rapidly progressive proptosis not responding to the IV antibiotics. So the eye was lost unfortunately, but luckily, due to the management, a good management, a life was saved. Thank you very much. Any questions regarding this presentation?
आपने एंटीबायोटिक उनकी स्टार्ट करवाई empirical therapy, so it's the liability of the doctor to send the sample for the culture sensitivity before the start of the any antibiotic. आपने empiric treatment किया, उसने response नहीं दिया, लेकिन
Yes.
आपके सामने वो चीज़ नहीं आ सकी कि उनको कौन सा इन्फेक्शन था. अगर
No,
जी सर, वो तो बाद में हिस्टोपैथोलॉजी में आया. इनिशियली आपको कल्चर सेंसिटिविटी करवाना चाहिए बिफोर. सर इन्फेक्शन आप एंटीबायोटिक स्टार्ट करवा रहे हैं तो आप ठीक है, आप एम्पेरिक थेरेपी तो ऑफ कोर्स आप उसको कह रही हैं. ओके ओके फाइन. यस ओके ओके थैंक यू.
Yes, sir. Sir, एक liposomal, we use liposomal amphotericin B. Liposomal amphotericin B. सर उसके साइड इफेक्ट्स कम है लाइपोसोमल जो है. सर मास्ट सेल रिएक्शन उसका बहुत ज्यादा होता है, उसकी वजह से
इसका मेजर साइड इफेक्ट रीनल फेलियर था ना.
रीनल फेलियर
जो इनिशियली जो
Yes, sir.
पुरानी थी उसके अंदर रीनल फेलियर, लाइपोसोमल जो है उसमें रीनल फेलियर इज मार्केटली लेस, लेकिन उसकी कॉस्ट बहुत ज्यादा है.
Cost
अगर वो 5-6 हजार का तो 40-50 हजार का मिलता था. चूंकि ये चीजें जब कोविड आया था तो दिस वाज वेरी रैम्पेंट, ये वाली म्यूकोरमाइकोसिस एट दैट टाइम. तो उस वक्त वी ट्रीटेड अ लॉट ऑफ पेशेंट्स और उसके अंदर ये चीज हमें पता लगी थी कि दिस इज द डिफरेंस बिटवीन द टू थिंग्स इन दैट सेंस.
Thank you very much, sir.
Thank you, Dr. Shuja. It was really a very wonderful presentation. Now I would call upon our next presenter, Dr. Maria, fourth year resident from I Unit 2 Mayo Hospital. Kindly come to the stage and give your valuable presentation.
Assalamualaikum. I'm Dr. Maria Khalid. I'm doing my training in I Unit 2 under the kind supervision of Dr. Nasir Chaudhary and Professor Raza Ali Shah. Everything that we're going to present today has been taken with patient's consent. So today I'm going to talk about an interesting case. A female patient, 35-year-old, presented to us in OPD on 6th of April 2023. She was a resident of Mandi Bahauddin and she was housewife by profession. She had a complaint of decrease of vision in the left eye from the last 9 months and decrease of vision in the right eye from the last 3 weeks. The only thing that it was associated with was floaters. The decrease of vision was painless in nature in both eyes, and there was no association with photopsia, redness, watering, or any kind of field loss or flashes. It was also gradual in nature. When we took past history of the patient, the ocular history was insignificant. She was not hypertensive, not diabetic. She had no allergies. There was no history of systemic medication. The family history was also not significant. The only positive clue we could find in the past history was that there was history of multiple blood transfusions at the time of birth of her second child. When we took systemic history of the patient, that was also not a significant, apart from the fact that she was complaining about a massive weight loss of 9 to 12 kg in the last 2 years. When we move forward to ocular examination of the patient, there was RAPD positive in the left eye and projection was also faulty in the left eye. IOP was 14 in the right eye and 15 in the left eye. Facial symmetry was normal, head posture was normal, muscle balance was normal, extraocular movements were normal, and rest of the anterior segment examination was also normal in both eyes. When we move forward, and we also did color vision in the right eye, which was intact, and then we move forward to fundus examination of the patient, and we saw that disc was pale in the left eye, which had a decrease of vision, let me remind you, from the last 9 months, and CD ratio was of 0.3 in the right eye. This was the picture of a patient's left eye. There was vitritis, which was mild grade 1 vitritis. There were extensive areas of subretinal, intraretinal, and epiretinal exudates in all 4 quadrants. There was retinal fibrosis and perivascular sheathing in the extreme periphery of the temporal arcades, and there were multiple flame-shaped hemorrhages all over the fundus. The right eye of the fundus had no positive finding except for the fact that there was vitritis and there were yellow-white small 5 to 6 intraretinal exudates in the extreme periphery of the inferior quadrant. We move forward to the systemic investigation, examination, which was also unremarkable. Then we sent the patient off for investigations and we had some differentials in mind, but I want to show you the fundus picture of the patient's right eye 5 days later when she came back with the lab results that we had ordered. We were shocked to see that the few deposits we noticed in the extreme inferior periphery had now moved to a massive subretinal and intraretinal exudative lesion involving an area of about 2 to 3 disc diameters outside the vascular arcade. Vitritis was still there and it was also associated with few flame-shaped hemorrhages. That's when we understood the aggressive nature of the lesion that we were dealing with. So we had a few differentials in our mind because you see the patient had a picture of multifocal retinitis with a slight degree of vasculitis associated with it. So it could have been idiopathic, could have been associated with a systemic inflammatory disease, could have been viral retinitis with vasculitis, for example, CMV retinitis or herpes simplex retinitis manifesting as ARN or PRN. Could have been protozoal retinitis, most probably toxoplasmosis, or it could have been bacterial in nature, for example, tuberculosis. The first lab report that she put in front of us was also very disturbing because till that point she appeared normal. She was fine. She was young. We were not suspecting that the patient could have been immunocompromised due to any reason. But the CBC showed a lot of deficiencies. She was anemic. She was neutropenic, and there were many deficiencies which we don't normally find in a young healthy adult. So just to be sure, we also ordered HIV and that came out to be positive. The normal value was 1 and patient's value was 878. The rest of the labs we had already ordered were also taken. Serum CRP was also ordered to find out any systemic inflammatory lesion going on, and that was in the normal range. Serology was done for CMV, IgG and M both were ordered. IgG was positive, but IgM was in the normal range. Serum HSV serology was also done. That was also positive for IgG, but negative for IgM. Serum toxoplasma serology was done. that was negative for both IgG and M. TB Gold was also done, that was in the normal range. HRCT was done, and the report was normal for HRCT. The last report that we had was something which was really significant and really helped us to get to our final diagnosis, because that was of CD4 cell count. And the patient's CD4 cell count was 59. And the viral load was also 24 lakh 17,000, which is very, very high. These are the two things which are really significant when it comes to differentiating what kind of pathology we are dealing with. Because at this level of CD4 count, the most probable cause of ocular pathology is CMV retinitis. And the clinical picture was also suggestive of CMV retinitis, because it was similar to what we see in the fulminant form of CMV retinitis. So the provisional diagnosis of CMV retinitis was made. There were multiple treatment options that we had. Three drugs are commonly used: ganciclovir, foscarnet, and cidofovir. Foscarnet and cidofovir are nephrotoxic, so these are mostly avoided. The one which is commonly used is ganciclovir, and there are two phases of treatment that we follow. The first is induction, and the second is maintenance. Now, since the patient had aggressive lesion and one eye was already lost, we had to save the other eye no matter what. So we went for aggressive management in the right eye, and 3 intravitreal ganciclovir injections were given at the interval of 1 week, and IV ganciclovir was also given for 2 weeks as induction dose. When we gave intravitreal injections, PCR was also sent in, for vitreous tab, and it came out positive for CMV retinitis. So the diagnosis was further confirmed. Then we put the patient on maintenance dose, which was in the form of valganciclovir 900 milligram OD. And when we discharged the patient, she had 6/6 vision in the right eye. We strictly followed her, counseled her for follow-up, because these patients should be monitored as long as the CD4 count remains below 200, because that is the only thing which helps us to get better vision out of the patient. Because if the CD4 count remains low, we have to continue this maintenance dose for as many days as it requires. And of course, the patient was sent to medical department for HIV treatment, and she is still undergoing HEART, and they also carried out investigations for VDRL, and that came out to be negative. So the take-home message over here is that even if the patient appears normal and fine, and she is young and apparently healthy, and even if you don't find any clue in the history, the patient might be immunocompromised, and HIV is something which is prevalent and it's mostly underdiagnosed, and we don't normally screen for it when we're considering patients with multifocal retinitis. Thank you. Any questions?
I'm Dr. Shabana.
Yes, ma'am.
बेटे आपने डायग्नोज किया, बहुत अच्छी प्रेजेंटेशन थी, वेरी वेल डन। आप मुझे बताइए, जब आप इंजेक्शन दे रही थी तो आपने अपनी प्रिकॉशनरी मेजर्स क्या लिए थे?
मैम उनसे एक सेपरेट किट मंगवाते हैं हम, पूरी की पूरी डिस्कार्ड होती है किट, एंड एवरी टाइम वी गिव हर दैट इंजेक्शन, वो एक सेपरेट किट ही लेके आती हैं। एंड अपने भी हम ज़ाहिर डबल ग्लव्स वगैरह वो सारे यूज़ करते हैं। इसमें जो पिक्चर है, आई वॉज द वन गिविंग हर द इंजेक्शन, एंड वी वर वेरी कॉन्शियस। ये सारी चीज़ें मैंने फिर डिस्कार्ड करवाई थी। इवन द टेबल वॉज नॉट यूज फॉर एनी अदर प्रोसीजर आफ्टर दैट। और उनको भी गाइड किया था, सिस्टर को भी, एवरीबडी वॉज गाइडेड कि दिस इज़ द table on which HIV patient has been dealt with. Thank you.
Thank you very much. It's a very nice presentation. इसमें my question was initially जो आपकी finding थी hemorrhages और cotton wool spots नजर आए, तो what was the pattern of regression? Did they develop any retinal holes in this patient
No.
in the periphery later on?
Yes, it's a very good question, sir. The lesion was static after that. The patient was on 2 monthly follow-up, and the size of the lesion was continuously being monitored. It was about 2.5 disc diameters, and it was the same size on the progressive, on frequent visits as well. But in unfortunately in the left eye, the vision was already faulty projection, and whole of the in all four quadrants there were retinal necrotic areas, so that could not have been saved. But vision is static; it's 6/6 in the right eye still, and we are still continuously monitoring the patient as long as she's undergoing heart and the CD4 count remains low. It's stabilized, yes. So the hemorrhages have reduced in number, but they're still there. Vitritis was cleared. After the first injection, the vitreous was clear, and it's still clear. Yes, yes sir. We have to monitor it because it can reoccur. If the CD4 count remains below 200, there is a possibility that the lesion can recur anytime. So the only tool we have in fighting CMV retinitis is getting a better management for AIDS. Like the heart has to improve, CD4 count has to improve, and that's the only way for us to fight CMV retinitis. Otherwise, we might have to give this maintenance dose for the rest of patient's life. There's no other way. And yes, one more thing I forgot to mention was the cost of this maintenance treatment. Well, ganciclovir, it's very costly no matter what pharmacy we go to. It costs about 85,000 for 15 to 20 days of medicine, and the patient was not she wasn't financially able to continue her medicine, and we had to. Ji, sir. Yes, sir. So yes, it was given in the form of intravenous earlier because of complications of IV catheters, and that was the reason that oral treatment was initiated.
The one thing was that this disease, it had got an intraretinal, subretinal, and epiretinal exudation with the hemorrhages in the one eye, and there was a pale disc which
Yes.
was present in the left eye. The right eye had vitritis, uh, 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 and this vitritis, and also had this intraretinal and subretinal hemorrhages, but they were not in the posterior pole, that was periphery. But when we gave this injection intravitreal, it subsided, and the vision, which was 6/12 partial, it came to 6/6 partial. Now the thing is that this van gang cyclovir, it is very costly. The patient is poor and she can't afford, and she was literally crying that I can't afford 85,000 rupees every 15 days. So we have sent an application to Bethel Mall that support this patient, and also
Yes, sir.
had sent this, informed this HIV center as well that
Yes, sir, we have.
we have received this case, because it is one of a unique case which we don't see often.
जी बिस्मिल्लाहिर्रहमानिर्रहीम। सर मोइन साहब ने ये रेजिडेंट के लिए भी है, बड़ा अच्छा क्वेश्चन रेज किया। अच्छा, बेसिकली ये कि हम देखते हैं कि दिस इज नॉट ए फ्रीक्वेंटली एनकाउंटर्ड सिनेरियो इन आवर सेटिंग नॉर्मली, लेकिन क्योंकि पेशेंट की हिस्ट्री थी ब्लड ट्रांसफ्यूजन की, अगर आप हमने जब इंट्राविटल इंजेक्शन जब स्टेज पे लगाया, उस पर हमने पीसीआर कराया, पीसीआर की रिपोर्ट CD4 की जो अकाउंट था दैट वाज लेस देन 50। ये सारी इन्वेस्टिगेशन, और बाकी ये कि जब ये हमने पेशेंट की फंडस देखी तो जो रेजिडेंट के लिए है कि हमने इसको टीबी से रूल आउट किया। अब टीबी में नॉर्मली ये देखते हैं कि ग्रैनुलोमेटस यूवाइटिस जो है वो आपको एंटीरियर सेगमेंट में जो ग्रैनुलोमेटस यूवाइटिस के साइंस इन द फॉर्म ऑफ केपीज नजर आएंगे। विट्राइटिस मोर लाइकली होगा इन टीबी में। अगर आप देखें जितने भी इम्यूनो डेफिशिएंसी पेशेंट्स में विट्राइटिस होगा, लेकिन रिलेटिवली कम होगा। अगर हम पीओआरएन की बात करें तो पीओआरएन नॉर्मली जो मैकुलर एरिया को इन्वॉल्व करता है और उसके जो हेमरेजेस हैं इतने डीप नहीं होंगे। और अगर हम एआरएन की बात करें, इससे इसके डिफरेंशियल में रखा है, तो एआरएन जो है वो पेरिफेरी को ज्यादा टारगेट करता है, और उसमें भी आपको इतने डीप किस्म के मैसिव किस्म के हेमरेज, और इन दोनों में पीओआरएन और एआरएन में इतनी आपको शीदिंग नहीं नजर आएगी जितनी इसमें होती है। इसके अलावा वीडीआरएल, क्योंकि इसका नेगेटिव था, टॉक्सोप्लाज्मोसिस में ये कि टिपिकल उसकी जो पॉइंट्स आउट पिगमेंटेड लीजन वो नहीं था। हमने इन सारी जो डिफरेंशिएट करने के बाद फिर लैब के रिजल्ट के बाद वी रीच एट द कंक्लूजन कि एक में फल्मिनेंट है, एक में फल्मिनेंट है जिसकी पीएल नेगेटिव हो गई, दूसरे में इंडोलेंट था। और इसमें अब जो सर ने क्वेश्चन जो रेज किया दैट इज वेरी इंपॉर्टेंट कि ट्रीटमेंट के बाद हमने क्या किया, गेंसिक्लोवर इंटरप्रेल दिया एट द 3 वीक इंटरवल। हमने उसके बाद 2 वीक्स के लिए उसको इंजेक्टेबल भी दिया, क्योंकि जाहिर है ओरल के रिजल्ट्स जो हैं अकॉर्डिंग टू लिटरेचर इतने रिमार्केबल नहीं है इसको, क्योंकि इसमें होगा अगर आप सीधा स्ट्रेट में इसको ओरल पे ले जाएंगे या मेंटेनेंस थेरेपी पे ले जाएंगे तो उसमें रिलैप्स होगा। जो सर बात करना चाह रहे थे मोइन साहब, दैट वाज इसमें जो अब हमारा जो कंसर्न है कि पेशेंट को रिलैप्स से रोकना है हमने। दूसरा इम्यून जो रिएक्टिव जो यूवीआइटिस है, इम्यून रिकवरी यूवीआइटिस है, उससे रोकना है। तीसरा ये है कि इसमें क्योंकि जब इतने डीप हेमरेज इंट्रा रेटिनल सब रेटिनल हेमरेज होंगे, इसमें रेटिनल नेक्रोसिस स्टार्ट हो जाता है, दैट विल लीड टू द फॉर्मेशन ऑफ होल। तो होल बनेंगे तो रेटिनल अटैचमेंट होगी। तो सो वी हैव टू लुक फॉर दीज थ्री थिंग्स: retinal attachment to the whole, immune recovery uveitis and relapse इसका। तो इसी वजह से हमने इंट्राविट्रियल जो इंजेक्टेबल के साथ, और इसमें जो सबसे जो स्टैंड आउट रोल करता है दैट इज हार्ट थेरापी। वो हमने मेडिसिन वालों को कहा, वो करते रहे। तकरीबन शायद इसका ऑकुलर का इतना स्टैंड आउट रोल ना करे जितना कि हार्ट का है, कि विद द एडवेंट ऑफ हार्ट थेरेपी तकरीबन मोर देन 50% चांसेस हैं कि इसकी जो है प्रोग्रेशन डिक्लाइन हो जाती है। तो द मेन स्टेज, जो मेन रोल है दैट विल बी हार्ट थेरेपी, फॉलोड बाई हम इसको असिस्टेंस में दे रहे हैं और इसको क्लोजली फॉलो अप पे रख रहे हैं। ठीक है, थैंक यू वेरी मच।
ऑन अ लाइटर नोट, ये इस केस को कौन ऑन करता? तुम करते हो, रजा करता? ऑन इसकी ट्रीटमेंट को कौन ऑन कर?
सर इसमें ऑन जो है देखिए, ऑन हम
रिकॉर्डिंग हो रही है
जी जी
रिकॉर्डिंग हो रही है
जी सर इसमें नहीं, सर उसमें देखिए इट इज बीइंग डन अंडर द डायरेक्शन ऑफ रजा साहब। इसमें इसमें जो
मैं
केस
पूछना क्या चाहता हूँ कि ड्रैप ने इंट्राविट्रियल दी हुई है आपको इंजेक्शन की?
सर वो ऑफ लेवल हम यूज
आप कहेंगे मैंने करके देखे।
और सर इसमें मैं सर की बात को आगे बढ़ाते हुए, दिस केस वाज क्लोजली मॉनिटर्ड बाय आवर सीनियर रजिस्ट्रार डॉक्टर इरफान एंड डॉक्टर मारिया, और इट इज अंडर डायरेक्शन ऑफ रजा साहब।
आराम से निकल जाना बाहर।
Thank you, Dr. Maria. Your excellent presentation is actually a true reflection of your whole team's hard work, and it has generated a very fruitful discussion among the audience. Ladies and gentlemen, now I would like to invite our next presenter, Dr. Irfan, third-year resident from I Unit 1 Mayo Hospital. Kindly join the podium and give your presentation. On behalf of Institute of Ophthalmology, Mayo Hospital, we warmly welcome Professor Jaliluddola.
Assalamu alaikum. My name is Dr. Irfan Ali. I'm third year PG trainee from I Unit 1. My faculty discussants are Professor Dr. Intizar Hussain, Professor Dr. Ali Iyaz. The case presentation that I am going to do today is female patient, 14-year-old resident of Lahore, admitted on 2nd October 2023 via OPD with chief complaint of upward deviation of left eye since birth. Upward deviation was gradual in onset, progressive from last 2 years, constant. Associated with left decrease of vision that was gradual and progressive. No other association, no aggravating relieving factors, and no diurnal pattern noted. Systemic review was insignificant of fever, fits, trauma, and other systemic history. Patient has history of usage of glasses, not a change in last 6 months. There was positive history of lamellar splitting of left upper lid and cryotherapy that was done in I Unit 1 in 2021 for dystichiasis. Past medical, birth history, and family history were insignificant. On examination, visual acuity with glasses was 6 by 9 partial in left eye and 6 by 6 in right eye. Confrontation visual fields were full bilateral. Hirschberg was 15-degree hyper in left eye, whereas it was central in right eye. MRD1 was 2 mm where in left eye, whereas it is 3.5 mm in right eye. Rest of the examination, AC depth, Purkinje images, pupillary reflexes, regurgitation tests, digital tonometry was within normal limits. Anterior segment examination was within normal limits except for upturned palpebral fissures bilateral. On fundoscopy, there was cup to disc ratio 0.2 bilateral. Disc margins were clear and macula, and rest of the retina was within normal limits. On compensatory head posture, patient had right head tilt and right face turn. On cover and cover for both far and near, with and without glasses, on covering a right eye, left eye takes fixation but loses its fixation on first blink. On covering the left eye, right eye maintained central fixation on cover and cover. On alternate cover and cover tests, there was left hypertropia. In extraocular movements, as we can see in this primary gaze position, there is left hypertropia, which we refer to as the left over right hypertropia. And in the right gaze, in the left eye we cannot see the cornea. So while the eye is adducted, there is over elevation. So we have marked it as +4. While in the left eye, in dextrodepression, there is some restriction. So we have marked it as -3. Rest of the ocular movements in the left eye and the right eye were full. On prism cover test in the primary gaze, at far left there was left hypertropia 30 plus 14 prism diopters. In left gaze there was no hypertropia, whereas in right gaze it worsened to 30 plus 18 prism diopters. On prism cover test at near target there was left hypertropia of 30 plus 14 prism diopters. Head tilts were done, and on right head tilt, the hypertropia improved to 20 prism diopters, and on left head tilt, it worsened to 30 plus 18 prism diopters. Fundus torsion was +2 fundus excyclotorsion. Then the part 3 test was done. As we can see in the primary gaze, there is left hypertropia. So in the first step, we will isolate superior oblique and inferior rectus in the left eye, and superior rectus and inferior oblique in the right eye. And as we can see in the right gaze is worsening as compared to the left eye. So in the next step, we will isolate inferior oblique and superior oblique of the left eye, superior rectus and inferior rectus of the right eye. As we saw in the previous slide that hypertropia was worsening in the left tilt, whereas it was improving in the right tilt. So our next step, we will isolate superior rectus and superior oblique in the left eye and inferior oblique and inferior rectus in the right eye. So this is how we came up with one of our diagnoses of left superior oblique palsy. This was the 9-gaze pre-op assessment of the patient. Our DDs were superior oblique palsy, primary inferior oblique overaction, myasthenia gravis, thyroid eye disease, skew deviation. All of these present with vertical diplopia, but if we see in myasthenia gravis, there's intermittent vertical diplopia and ptosis, muscle weakness that improves over the course of day. Thyroid eye disease is a restrictive myopathy that is associated with rectice. Obliques are less frequently affected, and there is proptosis also. In skew deviation, we will find bilateral torsion and or encyclotorsion on double Maddox and fundus photography. And if we change the position of the patient from upright to spine position, the torsion changes. Whereas in superior oblique palsy, it remains the same. So our final diagnosis was superior oblique palsy of the left eye. We treated the patient surgically. While doing surgery on a force reduction test, left inferior oblique muscle was too tight. So did 8 mm left inferior oblique myectomy. What we did in addition was right eye inferior rectus recession 5 mm, along with replacement pexy of capsulopalpebral fascia. At the end, force reduction test was done again and inferior oblique tightness vanished. This is one of the still from Dr. Elias doing the inferior oblique myectomy. As we can see, the inferior oblique muscle is isolated and 8 mm measurement is done, and after securing the hemostasis with this RT clamp, muscle is cut at 8 mm. Now this part The remaining of the muscle reflects back to its position, and the remaining stump from the origin, from the insertion to the cut end is removed. So this is how inferior oblique myectomy is done. This was the post-op picture of the patient. And as we can see in the primary gaze, there is no hypertropia along with all the gazes, and the compensatory head posture also improved after that. Now, what is inferior oblique overaction? Inferior oblique overaction presents as over elevation when the eye is adducted. It can be primary or secondary. It is said to be primary when it is bilateral and is associated with horizontal deviations. It is said to be secondary when it is unilateral and is due to superior oblique palsy. Superior oblique palsy mostly is congenital, and its decompensation occurs later in life due to fusional incapability. Now, if some patient has trauma, then it will present as bilateral superior oblique palsy. Sudden onset of vertical diplopia in absence of ptosis combined with compensatory head posture always strongly suggests fourth cranial nerve palsy. What does the research say? There are multiple inferior oblique weakening procedures like myectomy, recessions, anterior transposition, myotomies, Z-myotomies. But the success rate between all these has always been a debate. One of the research that I have mentioned here, I have given the link, was done by Dr. Ali Yaz and colleagues in Boston Children's Hospital. It is a retrospective study that shows that myectomy is superior to recession. Reason being, whether we do myectomy or recession, the final position of the inferior oblique muscle is the same. So it's better to do myectomy than to apply stitches and do recession. This also shows that the inferior oblique muscle, this is an important point, that the inferior oblique muscle has a self-grading effect, self-adjusting effect. That means the greater the preoperative deviation, the more the inferior oblique self-adjusts itself. Self-grading effect of inferior oblique is 5 to 20 prism diopters. One other important thing that was done in this surgery was the replacement pexi of capsulopalpebral fascia. By that I mean to say that capsulopalpebral fascia was adjusted. As this is the anatomical review, this is the inferior rectus muscle, and this is the capsulopalpebral fascia originating, enclosing the inferior oblique muscle and reflecting over the orbicularis and inferior tarsus. So whenever we resect or recess the inferior rectus muscle, it will later on present with lid retraction. So why not to combine this surgery with while doing the strabismus surgery? So that was actually done in this surgery. So take home message is, whenever we do surgery on inferior rectus, always adjust capsulopalpebral fascia at the time of the strabismus surgery. I have given the links of these two surgeries down here and along with my email ID. So if you want to contact me regarding that, you can. Thank you so much. If any there are questions, you may ask. No, sir. Sir, this was totally followed from 2021. So we did cryotherapy and the oculoplasty procedure, and then we later on did. Sir, this, so this patient hadn't the diplopia because of the compensatory head position. So she was maintaining that position, so that's why she didn't present with the diplopia.
सर्जरी के बाद तो वो compensatory head position change होगी होगी.
जी sir, it was improved, but there was still some that was improved later on. So she came with on the first follow-up, and it was totally improved.
यार एक हेड टिल्ट टेस्ट होता था, हेड टिल्ट टेस्ट, वो जरा एक्सप्लेन कर दो, मैं भूल भाल गया. व्हाट इज हेड टिल्ट टेस्ट?
So whenever a head tilt test is done, so if we are doing the right head tilt test, so that where the head is tilted, that eye intorts, whereas the other eye extorts. So we are actually checking the torsional movements of both eyes. So that's why I showed this palsy step test, that first of all, the primary gaze was checked. So like there is hypertropia. So the hypertropia can be is due to the weakening of superior oblique and inferior rectus muscles. And the hypotropia can be due to the weakening of the superior rectus and inferior oblique muscles. Then we check the gazes. So it was worsening in uh, right gaze, as we can see here. So then I marked this and the right gazes. Then was the head tilt, which was to check the torsions, and at the left head tilt, that hypertropia worsened to 30 plus 18, whereas it was improving on right head tilt. That was 20 prism diopters. So that this is how we isolated the superior oblique muscle. Sir, left superior oblique palsy with inferior oblique overaction. No, sir, those three lines are basically, we have to see these three lines. Sir, so these are the first two lines. The next two lines were these, and the third line was intersecting superior oblique.
बेटा सेकंड लास्ट स्लाइड दिखाना इससे पीछे हाँ बस just as a memory of the golden era of Professor Minul Laksab and Professor Jalil Dola Sahab. So we all know that we usually do transconjunctival inferior oblique recession. But I have assisted Professor Minul Laksab about 12 to 13 cases of inferior oblique recession through skin, not through transconjunctival.
Right.
He used to give incision along the medial one-third of the inferior orbital margin, and immediately he approached the inferior oblique.
Right,
And
sir.
he did all the inferior oblique recession through that approach
approach.
in no time. So we do through transconjunctival, we expose the muscle, that takes a lot of time. But that was the minimal time I have ever seen doing inferior oblique recession through the skin approach. So you give incision along the medial one-third of the inferior orbital margin, expose the orbit, and you immediately approach the inferior oblique muscle.
Right. Thank you, sir. So, any other questions? I think that's all. Thank you so much.
Thank you, Dr. Irfan. This was really a mystery to solve only on the basis of clinical expertise and the most enlightening, of course. All our presenters are doing very well and the fingers are crossed. Ladies and gentlemen, let's call upon our last presenter, Dr. Ikra Shamim Ahmed, third year resident from I Unit 3 Mayo Hospital, Lahore. Kindly join the podium for your case presentation.
Assalamu alaikum everyone. I am Dr. Ikra Shamim Ahmed, resident ophthalmologist, I Unit 3. Today the main focus of my presentation is going to highlight the savior. There is no financial disclaimer to make and this case is only being presented after obtaining a proper consent from the patient. Coming to the learning objectives, we should be able to identify the signs of fungal keratitis, treatment of fungal keratitis, and to formulate a management plan of resistant fungal keratitis. Well, this is a case of a 30-year-old male who presented to us with eye pain, photophobia, tearing, and lid swelling. Well, he gave us no history of vegetative trauma, topical steroid use, or contact lens use. On ocular examination of the right eye, it revealed a best corrected visual acuity of 636, a corneal ulcer measuring 2 into 1.5 millimeters with corneal infiltrates. The intraocular pressure was slightly raised with a sluggish pupillary reflex. However, the fundus examination of both the eyes was normal. This is the picture which is showing a corneal abscess. Well, this is a condition on presentation. We actually removed a plastic foreign body which was attached exactly right here, and the abscess was adherent to the plastic foreign body. Now, with the history and the clinical picture, what all differentials we came up were bacterial keratitis was topmost. Then we had fungal keratitis, acanthamoeba, herpetic keratitis was another potential cause, and then we also removed the plastic foreign body, so a retained foreign body was also present. Well, initially the patient was treated for a presumed bacterial keratitis with moxifloxacin and fusophthalmic drops. Cycloplegics, subconjunctival antibiotic tropramycin was given, and intrastromal moxifloxacin was also given. This patient was seen every third day. The ulcer initially responded very well to the treatment. The size of the abscess also reduced. However, on the third visit, the patient complained of increased blurring vision, redness, burning, and eyelid swelling. Additionally, the slit lamp examination revealed an increase in the size of the corneal infiltrate, increased dryness of the lesion, and satellite lesions with a dense hypopyon. Now, this is the picture here. The visual acuity continued to decrease. A very severe subconjunctival hemorrhage, hyperemia was present. A very prominent, large, irregular, whitish, feathery infiltrate with satellite lesions was observed. A thick hypopyon was also present. Now, because of all the worsening symptoms while on antibacterial and an unclear etiology with which the patient presented to us, the patient was additionally prescribed topical natamycin. Oral itraconazole was also prescribed. Corneal scrapings were sent for 10% KOH staining, and intrastromal voriconazole was also injected at 3 to 4 sites in divided doses. Well, the KOH wet mount came back positive for fungal hyphae, which further aided us in our diagnosis of fungal keratitis. The intrastromal was repeated every third day. The size of the infiltrate and the hypopyon reduced again. However, with the last intrastromal voriconazole, it resulted in spread of the disease along the needle track and a flare-up. The vision deteriorated further, coming down to hand motion. Now, this is the clinical picture. The abscess got attracted while we gave the intrastromal, and now it had increased to a size of approximately 4 into 5 millimeters with a dense hypopyon. Now, this is just a timeline for comparison. Initially, if you see, it started with 2 into 1.5 millimeters with the vision of 636. However, we started topical antibacterials, and then around the 12th day, this is where the condition started to deteriorate. We also had a clinical picture to aid us in the diagnosis of fungal keratitis. So we started fungal antifungals around here. The condition again improved, and with the last intrastromal, the condition deteriorated, which actually resulted in the flare-up of the disease process. Well, we reached a diagnosis of resistant fungal keratitis. Our management plan was revised as fungal keratitis is very difficult to treat and it often has a very long protracted course. Topical fortified amphotericin B was added and renal and liver profiles were monitored weekly. A combined intrastromal and intracameral amphotericin injection was planned initially. However, the patient got lucky and the donor corneas were available the very next day. Option of amphotericin versus a therapeutic keratoplasty was discussed with the patient. The patient opted for a surgical management. Now, with therapeutic penetrating keratoplasty, we were aiming for eradication, complete eradication of the fungal infection as our primary outcome. and preservation of the anatomical integrity, graft survival, and a good visual outcome as a secondary aim. Therapeutic penetrating keratoplasty was done. A huge donor tissue size was created owing to the fact that the abscess had completely covered the inferior cornea. Post-operatively, steroid was delayed for a period of 1 week and then commenced. Topical antifungal, antibiotics, and cyclosporin was initiated. This is the before and an after of how well the graft is surviving, how it all started, and with the availability of the corneas and also the prompt decision of the patient. Does it all end here? Well, no. A very close follow-up is essential and very much required for any fungal relapse or signs of graft rejection to be noted. This is the present day scenario, which is yesterday. He has a clear graft and a best corrected vision of 618. IOPs is being monitored regularly. It's 13. There are no signs of rejection of fungal recurrence. However, there is cataract formation and synechial formation as well. The B scan is normal. The patient is very much comfortable and has no active complaints. A little literature review. According to the mycotic ulcer treatment trial, they found that natamycin was superior to voriconazole in treating fungal keratitis. In a study conducted by Mahmood et al., intrastromal corneal voriconazole is also very effective treatment of fungal keratitis. 88% of the patients showed improvement. Now, coming to the conclusion of my case, graft survival may be poor than when done in an inactive scarred cornea. And lastly, a huge thank you to Sir Asad Sir Muin, Madam Shabana, Dr. Sidra Latif, for your encouragement and support. Thank you, everyone.
Ikra, very interesting case. Can you let me know what was the size of the graft you placed and what are the complications in such a graft when you have, especially this was a therapeutic, this was a graft that you placed in at that time?
So the graft size was initially aimed at for 9 millimeters, and the recipient bed was around 8.5 millimeters. The complications can be signs. They can be signs of graft rejection, and also raised IOP, inflammatory glaucoma can result because the graft was very limbal to limbal.
Question tha कि the one thing I wanted to point out, that when you take such a big graft, you are encroaching on the angle, and the
The angle,
chances
yeah.
of glaucoma
Glaucoma.
are pretty high in very large graft. And the other thing which is very high is graft rejection is pretty high because you are so close to the limbal blood vessels, because all the grafts survive best. Keratoconus has got the best outcome because it is in the most avascular part of the retina and there are no blood supply over that area. The closer you are to the limbus, the less chance of survival of a graft you have.
इसमें basically we waited for about 3 weeks. 3 weeks after giving intrastromal, antifungal, intracameral, and we were now thinking that probably now this is going toward endophthalmitis because the primary source is in the cornea. It is not responding to anything. So only option was to yeah, did it, and during the graft around the inferior margin, it was very difficult to stitch because the margins were very friable. So it was very difficult because we did restitching twice in the infranasal quadrant because very friable margin.
Thank you, everyone.
I can only add a small piece of information. वो ये है कि ये जो बैक्टीरियल कैराटाइटिस होती है ना, इसका हाइपोपियन स्टेराइल होता है और फंगल केराटाइटिस का हाइपोपियन के अंदर फंगस मौजूद होता है, ये याद रखने की बात।
Thank you, Dr. Ikra, for extending the horizon in the management of resistant fungal keratitis, which is always challenging to everyone, no matter how expert you are. Ladies and gentlemen, this was the last resident's presentation. Moving forward, I would be pleased to announce the recorded presentation of our international speaker, Mr. Ashwin Reddy, consultant pediatric ophthalmologist, and who is also the lead clinician at Royal London Hospital. It will be a great pleasure to listen to his expertise and esteemed knowledge regarding intravitreal chemotherapy in retinoblastoma patients. Can we start the presentation?
I'd like to thank Dr. Chowdhury and Professor Moin. I'd like to thank Dr. Chowdhury and Professor Moin for the invitation to speak at this prestigious meeting at the Ophthalmological Society of Pakistan, Lahore branch. My name is Ashwin Reddy and I work at Moorfields Eye Hospital and the Royal London Hospital. Many of you will know Moorfields Eye Hospital. It's the best eye hospital in the world on a research basis. Very few of you will know the Royal London Hospital, but interestingly, this was the first English medical school, and many alumni, including Parkinson's disease, came from here, from Down syndrome, and Tay-Sachs disease came from this very hospital. So I'm going to speak about retinoblastoma, and Shaban Chowdhury came to our unit a few years ago, and here she is with Dr. Patel, my family, when she visited us. So I'm going to talk about retinoblastoma in the world, essentially. So it's the most common intraocular cancer to affect children. It affects 1 in 13,000 live births in high-income countries. In the UK, we don't have that many patients, just 50 new cases per year in 2 centres. It has a 98% 5-year survival group. And when we have asked all our paediatric ophthalmologists to refer patients into us, 35% will not have retinoblastoma. So it is a challenge, retinoblastoma. And it's a particular challenge if you have very low survival rates. But things are changing. So what I'm trying to do here is to encourage you to think about retinoblastoma and how you can get involved with treatment of retinoblastoma, because it's going to become a success story. It's very much a success story of many cancers, but it's going to be in Pakistan as well. It also involves clinical acumen. As I said, 35% do not have retinoblastoma. This is our paper in European Journal of Ophthalmology. So it is assessed clinically and then a decision is made whether it's retinoblastoma. You're not allowed to take biopsies. So it is intellectually very stimulating. So I've just recently been to a conference in Mombasa, which involved a lot of middle and low income countries talking about retinoblastoma. So why may you have low survival? Well, it may be related to prolonged lag time. And so there may be issues in primary care. And this is where Ministry of Health comes in. And I'll come back to the Ministry of Health. It may be acceptance of treatment, like enucleation. So many centres around the world, they will use photographs, pictures of prostheses. There will be support groups available. So parents whose kids may have had enucleation, but they don't want any other child to die with this condition, they are happy to speak to other parents. I'll talk about therapy called neoadjuvant chemotherapy. And as I've said, many units will use photographs of kids who look very well after their enucleation. And we need a multidisciplinary approach with the ophthalmologist, the pediatric oncologist, and the histopathologist. In the UK, we're fortunate to have many subspecialties and many groups involved, but this is a basic core. So many centres around the world got together and created a toolkit. So if you know very little about retinoblastoma, this journal, which is available, I can send it free. I can send it to Shabana. She can send it to you. It's called Community Eye Health Journal. It has a toolkit about retinoblastoma and the treatment of retinoblastoma. So why is it becoming a success story? So I've been involved in retinoblastoma care in low-income countries for well over a decade. And in 2010, when there were only a few centres in Africa treating retinoblastoma, the survival rate in Nairobi was 25%, and the survival rate in Ilorin was hitting about 50%. And now I've just come from the Mombasa meeting and spoken to my colleagues there. And in that Nairobi centre, remember this is centre based, so it's not everywhere, but it will be centre based. We have over 80% survival. And they got very involved with the Ministry of Health. Okay? And in Nigeria, it's over 80% survival now at this centre in northwest Nigeria. And they got very involved in their local state. So unless you get involved and you have senior colleagues and senior management who will help you, it's very difficult to move this forward. The World Health Organization is now interested in retinoblastoma at last. So they have written to every Ministry of Health in the globe, in the world, and highlighted retinoblastoma. So they're aware of this. So it's important for us as ophthalmologists in different countries to contact Ministry of Health regarding this WHO initiative, which we've been pushing for over a decade now. So these are survivals in good centres in Africa, low middle income countries. So what's the survival rate in Lahore like? Well, it has improved, but it is around the 70% mark. And it will always stay like this because of 10% absconding, so not having any treatment, and 21% having orbital disease. So if patients come in with orbital deaths, orbital disease, mortality will follow. And with absconding, we don't know where they went, but we can assume they may well have died. So how can you deal with a patient that comes to you and you wonder, are they going to stay in the unit? Are they going to abscond and leave the unit? Well, it shouldn't be an ophthalmologist who does the counselling. The ophthalmologist will have a large number of patients to see, maybe operating. So as Shabana knows, Dr. Chowdhury knows, in the UK, we have clinical nurse specialists who do a lot of counselling. So this obviously takes resources, but it does mean that that nurse or that counsellor follows the patient. So maybe they don't want to be seen, but that person, our nurses, will chase that family. They'll look for the family and chase them until they know exactly where they are and what's happening to them. So that takes time. So it shouldn't be an ophthalmologist who is doing that, but it takes resource. So the question is, do you want resource for a cancer that is treatable and that will kill children? And I think that is a resource worth spending on. A lot of families have already lost trust in doctors and the health service. So it's very good for them to have someone who's not within the health service, contacting them. That's very important. And that's why it needs time, and you need to have follow-up calls to find out exactly what's happening to this patient or this family. Maybe they can't afford the treatment. At least audit this, find out what's happening to these patients, because unless you have the figures, you can't improve matters. So I have a number of patients from United Arab Emirates that come to see me, and we are creating a patient support group there from one of my families who want to help other patients with retinoblastoma. Even 10 years ago, there was a family who came to me who'd seen 4 ophthalmologists in UAE who said this white thing at the back of the eye was nothing to worry about. So that was just 10, 12 years ago. So do you think that's happening in Pakistan? I suspect it's happening in Pakistan. So creating a patient support group is absolutely essential for this. So you would find a family who is literate and wants to move things forward to do that. Only then you can tackle that 10%. And why not involve religious individuals, imams? Why not involve mosques? We're talking about children who are dying. I'm sure they want to do something to help them. And finally, the Ministry of Health knows about retinoblastoma through the World Health Organization. Now it's up to ophthalmologists to contact the Ministry of Health and say you're ready to be supported, to get that resource, to try and reduce mortality in your country. Another method that can be used, and this is from Uganda, is what we call neoadjuvant chemotherapy. So so that means as soon as a patient comes in, you suspect they won't want a nucleation, so you just give them chemo, just to keep them within the hospital environment. And then they might accept a nucleation as you keep telling them, and they see other patients who have retinoblastoma. Otherwise, they'll run away. So this is 2006, 42% extraocular disease. Remember, extraocular disease essentially means death. However, reducing that to with chemotherapy, you reduce mortality from 55% to 35%. So use whatever strategy you have to keep these patients in hospital. So to get patients seen earlier, we use the white reflex, and we all know about that. But how long have you got? Do you have to see these patients within days? Now that's what we're all told, but we've published a number of papers regarding this, and really what you want to avoid is extraocular disease. And this is our paper from the UK regarding this. And in the UK, we don't have any extraocular disease. Therefore, we have high survival. So for you to get high survival, you need to reduce your extraocular disease. So to do that, you've got 6 months. And in Brazil, metastatic disease was 10 months. There's this lag time from first seeing the white thing in the eye to coming to a unit. In China, it's over 6 months. And in Mexico, it's not so strong correlation, but under 6 months extraocular disease and mortality. So you've got 6 months, so you have time. And Honduras, this is an excellent study. They found that before posters, there was 73% extraocular disease. So these are posters when kids are having vaccinations, talking about that white reflex. And after posters, extraocular disease reduced to 35%. So those two aspects, the absconding group and the group with extraocular disease, if you tackle those two groups, you could increase your survival. And you have the tools now with the Ministry of Health, but you need to contact the Ministry of Health and make them aware. Now, for the next few minutes, I'll talk about salvage. So this is something called intravitreal chemotherapy, first discovered in Japan. This is Shigenumi Suzuki, and this is my colleague Francis Mooney in Switzerland, who made the safety enhanced group. So we want to save eyes as well. We don't enucleate every eye. So if you look here, you can see vitreous seeds, but can you name the 3 different types of vitreous seeds there? And intravitreal chemotherapy can be very successful. Look at the effect here. Look on the left, we have lots of vitreous seeds. After intravitreal chemotherapy, they've all gone. So the types of seeds are spheres, dust, and clouds. And that's important because the number of injections vary dependent on whether it's dust, sphere, or cloud. And how do you do this? So I perform an anterior chamber paracentesis. Some people use a UBM before they inject 3 millimeters from the limbus. It's not essential. And in the UK now, we're giving 30 micrograms of melphalan and 20 micrograms of topotecan. And we're doing the same site with both injections and using cryotherapy on the needle and afterwards. And there are different techniques around as well. And some people just use topotecan and some people just use melphalan, but we use both. And we must be very important, must be aware that we do the wiggle, which isn't a dance, it's moving the drugs around the vitreous. And it's all evolving. We used to use 7 injections every 10 days. Now we just use 3 or 4 every 3 to 4 weeks. And we've got to make sure that the tumours that are shedding these vitreous seeds is treated, such as by intra-arterial chemotherapy. And the success rate can be very good. So I think my time's over now. Thank you very much for listening. I'm sorry that I can't be there to answer questions, but Dr. Chowdhury is there to answer my questions. And if she doesn't know, she can always contact me, and we can get back to you in due course. Thank you very much. I'd like to thank Dr. Chowdhury and Professor
That is our presentation by the worthy Vice Chancellor. He has arrived, so we are just going to wait for him. I would like to invite Professor Asad Aslam Khan, Professor of Emeritus, for any remarks about this. I would like to invite Professor Jaliluddola, ex-head of department at I department of Mayo Hospital, kindly join the podium and give your remarks regarding this presentation.
Okay. Thank you very much for asking me to pass comments. I hope my comments are taken happily because at time I become extremely unpleasant. So first thing which I notice here is that the quality of presentations and the pictures are really excellent. You know, in our days, the things were not so much developed. I recall the days when in 1975, I went to America and I had to purchase a macro lens to take pictures. And I used to place a book in open sunshine on a certain stand and then take the pictures from the book with a macro lens. And then the government would give me only $1,000 to travel abroad. And I spent something like $800 on that macro lens. This was very agonizing. But now there's a revolution, as you can see, things have changed so much. Uh, in first Shafi Memorial Lecture, if you recall, I presented photocoagulation therapy for various diseases, and all those pictures which I had taken were with that macro lens. They were all taken from a book. Uh, the unfortunate thing is that what I see here, still some of the stuff is taken from books. Can we possibly avoid it? Instead of taking pictures from the books and then presenting it here, we should concentrate more and more on clinical examination, personal experiences, and what we have seen. I I just mentioned head tilt test because it gave me an idea. I have already really forgotten to contradict you. I've honestly forgotten how to perform a head tilt test. But it was such a simple test. The patient comes with a compensatory head posture. You suspect that he has superior oblique palsy, and all you have to do is ask, ask him to sit straight on the chair and hold his head and tilt it towards his shoulder. You tilt the head towards his shoulder, and one eye goes up, and that would point out to the palsy. So ये जो प्रिज्म के साथ इवेल्युएट करना, मैंने इवेल्युएशन जो प्रिज्म के साथ कभी की भी है, तो आई यूज टू हैव ए प्रिज्म बार. आई डू नॉट नो हाउ यू कैलकुलेट कि इतने प्रिज्म की डिविएशन है. इट्स a cumbersome procedure. Uh, by the way, I would like to learn how do you measure in our orthoptic department here at Mayo. How do you measure the deviation with prisms? Because back in England where I was, they used to have a prism bar. It was a vertical bar, and they would gradually pass it up or down. You still have this? Which is very good. तो ये जो है ना
Sir,
किताबी
I just
चीजें
want a break here.
इसको
On behalf of Institute of Ophthalmology, Mayo Hospital, I warmly welcome our worthy Vice Chancellor, King Edward Medical University, Professor Mahmood Ayaz, a man of true leadership, a sign of hard work, a symbol of knowledge whose esteemed efforts are truly matchless. Respected sir, it's an honor for all of us to have you on this auspicious occasion. Kindly join the podium.
uh, नहीं, I think I will cut down my. I am very keen to learn to your robotic surgery which you are going to show.
जी सर, नहीं सर, पहले सर की सर की जो कमेंट दे रहे थे, पहले सर का कमेंट तो ले ले सर पहले। सर को माइक दे दो, वो तो मैंने आपको इंटरप्ट कर दिया। सर आपने कमेंट जारी रखिए।
So to continue, uh, something interesting which I have learned is how to inject antifungal agent into the stroma. How do you do this? Just with a small needle, tuberculin syringe, and how much you inject inside the stroma? Oh, the thing you inject in the vitreous, just like that. Yeah. Have you done some study on this particular case? How many cases have you done? Intrastromal function. Very good, very nice. Well, and this is very.
नहीं मैं आपको इतनी देर वेलकम करता हूँ नहीं
Well,
आपको
thank
मैं
you
कहा
very much. I'm very glad to be here, and I really enjoyed the session. And I come here really to revive the memories of the past glorious days with Professor Munirul Haq and Professor Raja Saab. I was collecting some old pictures from my clinic, which is under renovation nowadays, and I could see some of the old pictures where Professor Raja Mumtaz Sahab, Professor Munir Sahab, and even Professor Shafi Sahab. I had pictures with him. So I'm a feature of the past, and maybe in few years I will not be here, but it's good to see all those pictures. And please remember me in your prayers. Thank you very much.
Sir, thank you.
Just one remark, just to tell you the status of Professor. My uncle, who was a sitting Chief Justice at that time, he took his wife to Moorfield Hospital, London, about 30 years back. And Professor Richard the glaucoma specialist, and he diagnosed uh, the case of glaucoma. My uncle, okay, look, when you have a person like Dola in Pakistan, you don't have to come to UK. So this is what we had from Professor Mirul Aqsab. So this is what they have got the value, how not they are not only being respected in Pakistan but globally. How much respect Professor Hitching, Mike Falcon, J.D. Scott, they had Professor Jalil Saab. Only I can remember because I have the honor to be associated with him for the last 38 years. Thank you very much, sir.
Sir, thank you very much for coming and gracing the occasion. Before we start off the lecture from our worthy Vice Chancellor, I would just like to give a brief introduction. Although he is an Iqbalian, he is not a Kemkolian, but the way he's working for KE, I think, is unprecedented. And he's so many plans which are coming and which are forming and being accomplished. You could see that the new library and the new cafeteria which has been inaugurated, that was one of the plans. The next one is the emergency which is getting revamped, and the next he's promised us that he's going to get this ophthalmology department revamped, which is a big step for us and a big demand which we've been asking him to do this. So he's a very multifaceted personality. The reason I brought him to this talk, he's not an ophthalmologist by many far away. He's not an ophthalmologist, but he's going to talk about something which is everybody needs to know: artificial intelligence, robotic surgery. He's going to talk about the intestine and and general surgery, but the main aim is to get this idea across that this is something which is happening across the globe in every specialty, and we have to be prepared for this, and it's going to come and overtake our profession as well. Sir, I'd like to welcome Professor Mahmood Ayaz.
बिस्मिल्लाहिर्रहमानिर्रहीम अस्सलाम वालेकुम मेरा फिर वही मुतालबा है कि मैंने आपको सलाम किया शुक्रिया बहुत मेहरबानी आपकी थैंक यू वेरी मच इन फैक्ट इट्स अ ग्रेट ऑनर टू स्पीक in front of Professor Jalil Dawla. तमाम जो मेरे उस्ताद थे उनके करीबी दोस्त थे और मेरे लिए बड़े मोहतरम हैं और इत्तेफाक की बात है कि कुछ मैंने इनसे पढ़ा कुछ बाद में इनके साथ ताल्लुक़ इस तरह का रहा प्रोफेसर ज़फ़रुल्लाह चौधरी साहब की वजह से कि मैं अपने अपने आप को शायद मुझे नहीं पता, लेकिन मैं तो अपने आप को इनसे बहुत क्लोज समझता हूँ और मुझसे जब भी मिलता हूँ इंतहाई मुझे मुसरत होती है, खुशी होती है जब इनसे हाथ मिलाता हूँ। मुझे लगता है कि प्रोफेसर ज़फ़रुल्लाह चौधरी साहब से ही मैंने हाथ मिलाया है। तो सर आपकी बहुत मेहरबानी आज यहाँ पे तशरीफ़ लाएँ। और जिस तरह भी जिक्र किया मोइन ने कि आई एम नॉट एन ऑफ्थल्मोलॉजिस्ट एंड आई एम अ जनरल सर्जन, बट I'm a trained minimal invasive surgeon जिसमें वो छोटे होल्स करके तो आप ऑपरेशंस करते हैं। और मैं प्रोफेसर ज़फ़रुल्लाह चौधरी साहब के साथ, वो पायनियर थे पाकिस्तान में लेप्रोस्कोपिक सर्जरी के, मैं उनका शागिर्द हूँ और उनका बड़ा ख़ास शागिर्द था। उन्होंने जो कुछ मैं समझता हूँ कि मैं आज यहाँ पे खड़ा हूँ अल्लाह ताला और माँ बाप की मेहरबानी के बाद, सिर्फ उनकी वजह से ऐसा है कि उन्होंने मुझे इनेबल किया, इस काबिल किया कि मैं किसी मुकाम पे पहुँच सकूँ। और मुकाम आपका जो है ना, अगर कोई हासिल करते हैं तो सिर्फ अपनी स्किल की वजह से हासिल करते हैं, इसमें कोई और चीज़ शामिल नहीं होती है। सिर्फ आपके अंदर जो अल्लाह ताला ने आपको जो स्किल दी होती है, जो स्किल आप सीख लेते हैं, वही स्किल आपको आगे बढ़ने में आपकी मावन साबित होती है। कोई और क्वालिटी आपकी आपके साथ नहीं चलती सिवाय आपकी अपनी प्रोफेशन के अंदर, अपनी स्किल डेवलपमेंट के अंदर। तो पैगाम आप सबको ये है शुरू करने से पहले कि अपनी स्किल डेवलपमेंट में तवज्जो दें और यू मस्ट बी एबल टू एक्चुअली क्रॉस द बैरियर्स ऑफ न्यू नॉलेज। जितना न्यू नॉलेज है उसको हासिल करने की कोशिश करें। एंड यू मस्ट लर्न स्किल्स विच आर नॉट नोन इन दिस पार्ट ऑफ वर्ल्ड। इट्स वेरी इंपॉर्टेंट, क्योंकि जब आप स्किल्स हासिल कर लेते हैं और उसमें आप कमाल हासिल कर लेते हैं तो फिर द एंटायर वर्ल्ड हैज़ टू रिस्पेक्ट यू, हैज़ टू एडमायर यू एंड हैज़ टू लव यू। जिस तरह हज़रत अल्लामा इकबाल आपको बड़े खूबी से बता गए हैं कि कस्बे कमाल कुन के अजीज़ जहाँ शवी, जिसका मतलब है कि इफ़ यू अचीव एक्सलेंस इन योर वर्क, the whole world will admire you and respect you। और आपको उसका दूसरा मिसरा पता है? दूसरा मिसरा है कि कस्बी कमाल कमाल इल्म, यानी कि अगर आप अपने इल्म में और अपने विजडम में आप पीछे रह जाते हैं, हुनर में पीछे रह जाते हैं, ठीक है, तो उसके आगे लिखा है कि नेर जोबा नीम जो, कि आपकी कदर जो बारले सीड है उसे उसके आधे दाने के बराबर भी नहीं। तो ये डिफरेंस जो है ना हज़रत लामा इकबाल हमें बता गए हैं कि स्किल हासिल करना और एक्सलेंस की तरफ चले जाना किस तरीके से आपको दूसरे लोगों से मुमताज कर देता है। सो इट्स वेरी इंपॉर्टेंट टू अंडरस्टैंड द वैल्यू ऑफ मॉडर्न नॉलेज एंड द वैल्यू ऑफ मॉडर्न टेक्नोलॉजी एंड द एक्विजिशन ऑफ दैट स्किल, and not only the acquisition but then to actually distribute this skill to all the people who are available to you as your residents, as your colleagues, as your peers, सब के अंदर ये आपको डिस्ट्रीब्यूट करना, बिकॉज यही है जो आगे आपको लेके आपको इनकी तरवीज ही आपको जो आपको उस्ताद का दर्जा देती है और आपको ज़माने को मजबूर करती है कि आपकी रिस्पेक्ट की जाए। जिस तरह आज हम सब मजबूर हैं अपने दिलों से प्रोफेसर जलील दौला की, और ये फ्रंट लाइन में जो लोग बैठे हैं, मेरे दोस्त, हम सब जितने भी लोग बैठे हैं, हम मजबूर हैं इनकी इज्जत करने के लिए इस वजह से कि इन्होंने अपने अपने जो हुनर है उसमें कमाल हासिल किया, एक्सीलेंस अचीव की, and we are all there to respect them. So thank you very much for inviting me here today. I'll come back to the business. So I was about to talk on artificial intelligence and its use in minimal invasive surgery. और बात मैं आज यहाँ पे इसलिए कर रहा हूँ, not only that I perform robotic surgery, but as a university we are rapidly progressing towards this artificial intelligence. And we बात मैं आज इसलिए करने लगा हूँ कि we have already created a lab for artificial intelligence and it is a secluded area. It is not has been commissioned yet because we want to have all that expertise before as well. हमने इंफ्रास्ट्रक्चर सारा तैयार कर लिया है और सिर्फ हम अब एक्सपर्टीज हासिल करने की कोशिश करें कि हम आर्टिफिशियल इंटेलिजेंस में आगे बढ़ कैसे सकते हैं। जिसकी एग्जांपल है कि इस वक्त सिर्फ हमने 4th ईयर के 30 स्टूडेंट्स को लम्स में भेजा हुआ है जो आज जाके एज स्टार्टअप्स अपने आर्टिफिशियल इंटेलिजेंस पे अपने 30 प्रोजेक्ट्स करें। दे आर 4th ईयर स्टूडेंट्स ऑफ किंग एडवर्ड मेडिकल यूनिवर्सिटी और उनको लीड कर रही हैं डॉक्टर तहरीम फातिमा जो कि 4th ईयर रेजिडेंट है ऑफ न्यूरोसर्जरी यूनिट। और आपको ये सुन के इंतहाई मुसरत होगी कि एज अ 4th ईयर रेजिडेंट इस सारे प्रोग्राम के अंदर शी इज ऑलरेडी डेवलप्ड मॉड्यूल थ्रू आर्टिफिशियल इंटेलिजेंस जो कि ब्रेन ट्यूमर्स को लोकेट करने में न्यूरोसर्जन्स की मददगार साबित, इट्स अ नेविगेशन टूल एंड शी इज डन इट। और वो मैं अभी हवा में बात नहीं है, शी इज अ 4th ईयर रेजिडेंट वर्किंग इन द न्यूरोसर्जरी डिपार्टमेंट विद प्रोफेसर शहजाद शम्स एंड शी इज ऑलरेडी डन इट। और वो उनको लीड करिए 30 स्टूडेंट्स को कि हम किस तरीके से अपने आप को आर्टिफिशियल इंटेलिजेंस में आगे लेके जा सकते हैं, बिकॉज दिस इज द रिक्वायरमेंट, दिस इज द नीड एंड दिस इज द फ्यूचर। एंड इफ यू आर लेफ्ट बिहाइंड देन वी आर लेफ्ट बिहाइंड। क्योंकि मैं ये सुन के ना तंग आ चुका हूँ कि इंडिया ने जो है ना चांद पे अपना खलाई जहाज उतार दिया, जरूर उतारा होगा. All good marks to them. As an opponent, even I am ready to respect them for this because they have done their job. So what has happened to us? हमें क्या प्रॉब्लम है? हम क्या कोई मतलब नकल मतलब रंग नस्ल नकल शक्ल में उनसे कोई कमतर है? ऐसी तो कोई बात नहीं है. सिर्फ हम जो है ना अपनी डायरेक्शंस को थोड़ा सा खो बैठे, हम किसी और तरफ चल पड़े. So this is the direction. This is the future. We have to move towards this. So I'll start my talk about artificial intelligence and its use in minimally invasive surgery. अब आपको समझ में आ गई होगी कि मैं यहाँ पे क्यों खड़ा हुआ आपके सामने बात कर रहा हूँ. Have you understood my point? We are going to talk about artificial intelligence, we're going to talk about robots, and we're going to talk about what we are doing, and we'll tell you कि हम क्या कर चुके हैं अभी तक. ठीक है, ये कोई बाहर की बात नहीं है, ये मैं अमेरिका की सर्जरी की या बरतानिया की सर्जरी की बात नहीं कर रहा हूँ, मैं बात कर रहा हूँ इस वक्त पाकिस्तान की, what we are doing at the moment. So this is my topic, and ये क्यों हमें इसकी जरूरत पेश आ रही है रोबोटिक सर्जरी की तरफ जाने के लिए. Traditionally, when I was a resident, हमेशा हमें ना एक चीज़ पढ़ाई गई कि देखो big surgeons will make big incisions and mediocre surgeons will make middle grade incisions, और जो छोटे incision लगा के ऑपरेशन करते थे they were looked down upon कि ये तो जरूर कुछ ना कुछ गड़बड़ कर देंगे. But on the other hand, patients की क्या डिमांड थी? Patients wanted a surgery which should be safe, precise, पेनलेस विद स्मॉलर इंसिजन. ना सिर्फ छोटा इंसिजन है मतलब दर्द कम करता है, तो उनकी डिजायर ये थी. तो एक्चुअली व्हाट रोबोटिक सर्जरी हैज डन, इट हैज ब्रिज्ड द गैप बिटवीन द सर्जन्स परसेप्शन एंड द पेशेंट्स डिमांड्स. कि जो पेशेंट डिमांड कर रहे थे दुनिया में और जो सर्जन्स की परसेप्शन थी, उसके दरमियान उस गैप को जो ब्रिज किया कि हम किस तरीके से पेशेंट्स को, अल्टीमेटली एवरी रिसर्च एवरीथिंग इज वैलिड ओनली इफ इट इज ऑफ बेनिफिट टू द पब्लिक. अदरवाइज कोई रिसर्च, किसी रिसर्च का जो शेल्फ रिसर्च है ना कि आपने रिसर्च करके शेल्फ में रख दी है, इट इज ऑफ नो यूज. रिसर्च का फायदा यह है कि इट शुड बी बेनिफिशियल टू द पब्लिक एट लार्ज, ओनली देन यू विल गेट दैट रिकग्निशन. सो लकीली जिस वक्त जनरल सर्जरी में एडवेंट हो रहा था रोबोटिक सर्जरी का, द जनरल सर्जन्स वर ऑलरेडी डूइंग मिनिमल इन्वेजिव सर्जरी के छोटे छोटे होल से अपना काम करते चले जा रहे थे, और उसका एडवांटेज बेतहाशा था. छोटे होल्स थे, कम दर्द होती थी, जल्दी रिकवरी होती थी, बैक टू वर्क जल्दी था, कॉम्प्लिकेशन रेट कम था, मैग्निफिकेशन ज़्यादा थी. सो दी general surgeons were already doing that precision job before the robotic surgery. So robotic surgery was just like an extension of the laparoscopic surgery. और उसका फायदा क्या था? देखिए, कोई भी सर्जरी का जो मैग्नीट्यूड है ना, वो डिपेंड करता है कि the amount of metabolic insult that surgery creates inside the human body, and number two, the amount of the inflammatory response which the human body generates against it. तो जितनी metabolic insult कम होगी, जितना inflammatory response कम होगा, उतना ही अच्छी रिकवरी होगी, उतनी ही कम दर्द होगी, उतनी ही जल्दी मरीज बेड से उठेगा, उतनी जल्दी घर चला जाएगा, उतनी जल्दी जो है ना बैक टू वर्क होगा. So that is entirely dependent upon. So if laparoscopic surgery as compared to general surgery had a lesser amount of metabolic insult, had a lesser amount of generation of inflammatory response, robotic surgery was far ahead of that. So this meant a more quicker recovery. So it was proven, especially in the elderly, in the obese, there was a definite and distinct advantage. अच्छा, एडवांटेज क्या है? सबसे पहले तो यह है कि रोबोटिक सर्जरी में यू हैव गॉट अ बेटर विजुअलाइजेशन. आपको ज्यादा बेहतर नजर आता है. जब आप लैप्रोस्कोपिक सर्जरी करते हैं तो वो बेसिकली इट्स अ 2D विजन. जब आप रोबोटिक सर्जरी करते हैं तो इट्स अ 3D vision and it's a stereoscopic view. And I'm sure as an ophthalmologist you do understand what is stereoscopic view, because in the humans the two eyeballs, they are not exactly in the same position in the eye sockets. There's a fraction of a millimeter of difference. So that when my right eye gets an image that the object is here, the left eye gives me an image that the object is here, and the difference the brain calculates gives us the depth perception. So that is what is stereoscopic view. So जो आपकी रोबोटिक सर्जरी है, ये आपको बहुत ज़बरदस्त जो है ना ये स्टीरियोस्कोपिक व्यू देती है. देन रोबोटिक्स रिस्ट. देखिए, आज तक जितने भी जनरल सर्जरी में इंस्ट्रूमेंट्स डिवाइस किए गए या लैप्रोस्कोपिक सर्जरी में इंस्ट्रूमेंट्स डिवाइस किए, दे आर रिजिड इंस्ट्रूमेंट्स. आप कोई भी इंस्ट्रूमेंट उठा के देखते हैं, दे आर रिजिड इंस्ट्रूमेंट्स. ठीक है, एंड रिजिड इंस्ट्रूमेंट्स दे वर्क व्हेन वी मूव आवर शोल्डर्स एंड व्हेन वी मूव आवर एल्बोज. यहाँ पे काम करते हैं. लेकिन रिस्ट, जो आपकी रिस्ट है, इट्स अ वेरी वर्सेटाइल स्ट्रक्चर ऑफ योर बॉडी. So after 500 years of surgical instrumentation history, This was the first time that an instrument was devised which was just like a human wrist. It would not only rotate at 360 degrees, but it would come back and reflect backwards. And so there's a 720 degrees movements inside the human body. और अगर आप A.G. वेल्स की जो आउटलाइन ऑफ ह्यूमन हिस्ट्री पढ़ें तो उसमें लिखा हुआ है कि जो एवोल्यूशन ऑफ एनिमल स्पीशीज है, व्हाई ह्यूमंस दे गॉट superiority of other species, उसकी वजह उसने एक ही बयान की है, and that is the human wrist. उसने इंटेलिजेंस को, ब्रेन को नहीं कहा, उसने कहा जी अगर आप सिर्फ इंटेलिजेंस और इंस्टिंक्ट्स पे रहें तो जितने भी शिकारी जानवर हैं ह्यूमंस को खा जाए. उसकी वजह है कि उनकी इंस्टिंक्ट, उनकी इंटेलिजेंस शिकार करने की आपसे बहुत बेहतर है. सो इट वाज द ह्यूमन रिस्ट थ्रू विच इन्होंने तीर कमान ईजाद किए ह्यूमंस ने, इन्होंने हथियार ईजाद किए, इन्होंने खेती बाड़ी के इंस्ट्रूमेंट ईजाद किए, और उसकी वजह से इन्होंने तरक्की की और अल्टीमेटली तमाम बाकी स्पीशीज के ऊपर हावी होते चले गए. So he clearly writes down that in the evolution of the human species as the superior species all over the other species, the human wrist is the main factor. So here you have got an instrument which is exactly like a human wrist working inside the body. So that was the greatest advantage. And then improved kinematics, which means that the large external movements of your hands are reduced to very small refined movements inside the body. उसका फायदा क्या है? उसका फायदा ये है कि जब आप नुक्स एंड क्रेविसेस में, स्मॉल स्पेसेस में काम करते हैं, स्पेशली इन दी आई, जब स्पेस ही आपके पास नहीं है, एब्डोमेन में तो बेतहाशा स्पेस है और चेस्ट में बेतहाशा स्पेस है, जब आपके पास स्पेस ही नहीं है, उसके अंदर इंस्ट्रूमेंट्स के अंदर मोबिलिटी और फ्लेक्सिबिलिटी ऐसी होनी कि जो हम सर्जरीज कहते थे कि ये ट्यूमर्स इनऑपरेबल है, स्पेशली डीप डाउन इन द पेल्विस, राइट हाइपोकॉन्ड्रियम, लेफ्ट हाइपोकॉन्ड्रियम, वहां पर वो जाके इंस्ट्रूमेंट्स ज़्यादा इफेक्टिव साबित हुए और inoperable tumors, inoperable cases were declared operable. So I'll just show you how does it work. And then improved ergonomics, कि आपकी जो एक्टिविटी है बॉडी की, वो जो है ना, आप ज़ाहिर है जब आप सर्जरीज कर रहे होते हैं, आपके अगर शोल्डर्स की मूवमेंट ज़्यादा हो, एल्बोज की मूवमेंट ज़्यादा हो, तो आप थक जल्दी जाते हैं. सो इसमें ergonomics आपकी जो है इम्प्रूव कर देंगे इस तरीके से कि यू आर सिटिंग ऑन अ कंसोल, यू आर रेस्टिंग योरसेल्फ, and your elbows are placed on a pedestal and you're just working on your wrist, so you can get into, you know, hours and hours of surgery without getting tired. You don't have to get washed up. You can sit out, you know, on the side in the operating table, have a cup of coffee and keep on doing. मतलब cup of coffee का ये मतलब नहीं कि काम छोड़ के आप बैठ जाओ और आप मतलब कर, लेकिन वो ये because the robot is, मैं भी आपको दिखाता हूँ कि because that robot is noting that time कि आप एक्टिव कितना काम कर रहे हैं, आप सिर्फ कंसोल पे कितनी देर के लिए बैठे हैं और आप जो है ना बाकी टाइम कितना ज़ाया करें. सो इट इज़ अ कम्प्लीटली ऑडिटेड प्रोग्राम. वो आपकी एक एक चीज़ को नोट कर रहा था कि आप कैसे करते हैं, वो मैं आपको दिखाता हूँ ये कैसे करता है अभी थोड़ी देर में. सो नेचुरली जब स्टेरोस्कोपिक व्यू होती है तो आपको बहुत प्रिसीजन डिसेक्शन मिलती है, आपकी बेटर किनेमेटिक्स होती हैं, क्योंकि आपकी जो मूवमेंट्स है, अगर आप अपनी बाजुओं को देखें जिससे जिससे आप काम करते हैं, तो आपकी 7 डिफरेंट मूवमेंट्स होती हैं. पहली मूवमेंट तो आपकी शोल्डर पे है, जिसमें आप शोल्डर को आगे और पीछे लेके जाते हैं और ऊपर नीचे लेके जाते हैं. फिर दूसरी मूवमेंट आपकी तीसरी आती है जहां पे आप उसको रोटेट करते हैं. फिर एल्बो पे चौथी और पांचवी मूवमेंट आती है. फिर रिस्ट पे आपकी ये वाली मूवमेंट्स और ऊपर वाली नीचे. So there's 7 movements, and all these 7 movements are in unison reflected in a. So that is the greatest advantage कि बगैर आप अपने बाजुओं को बहुत चीज़ों को तकलीफ दिए हुए, बगैर बड़े बड़े मसल्स को इन्वॉल्व किए हुए, आप अपने छोटे मसल्स के साथ काम करके और आप लंबी लंबी सर्जरीज कर सकते हैं. So there are excellent ergonomics. So I'm just going to show you, this is the picture. Doing this robotic surgery for the last 1.5 years at National Hospital, और हमने अपना PC1 मंजूर करा लिया है गवर्नमेंट से, about 1.8 billion rupees का, and very soon inshallah in March we'll see that 2 robotic equipment will be installed in the surgical tower. And remember that this robotic instrument is not only for general surgeons, it is for urologists, gynecologists, orthopedic surgeons, eye surgeons, because eye की भी आपको हमें मोइन साहब बता चुके होंगे, there are a lot of surgeries क्योंकि high precision surgery है ना, आपके हाथ नहीं थकते, आपके ट्रेमर्स नहीं आते, आपको मतलब बहुत बड़ा एडवांटेज है, आप बहुत मैग्निफिकेशन भी देख रहे हैं. तो आई एम श्योर दैट यू ऑल मस्ट बी नोइंग दैट रोबोटिक कैटरैक्ट्स आर बीइंग परफॉर्म्ड, रोबोटिक विट्रोरेक्टल सर्जरीज आर बीइंग परफॉर्म्ड. सो दिस इज देयर, दिस इज, ये कोई डिस्टेंट फ्यूचर नहीं है, ये बहुत जल्द आपके सामने मौजूद होगा. सो दिस इज माय ऑपरेशन थिएटर एनवायरनमेंट ओवर हियर. ये तो मैंने सारा सेटअप किया था फॉर रोबोटिक रेक्टल कार्सिनोमा सर्जरी. तो मैं इसको मैं स्किप करने लगा हूँ. मैं इस I'll just check if the video works. So this is just the outline of the case which we had to do, and Yusuf narrates my karoon, and you can actually see I'm working down deep in the pelvis. This is my instrument, and you can see that it works like a human wrist. It can bend down, it can go up, it can move around, and this is the rectum, the lower part of the gastrointestinal system, and I'm just working with this instrument. इसका सबसे बड़ा advantage ये है कि आप इसको अंदर किसी भी एंगल में ना very short, otherwise जब हम पहले पेल्विक सर्जरी किया करते थे तो हमारी गर्दनें थक जाया करती थी, अंदर रोशनी अंदर जाती नहीं थी, हम किसी ब्लड वेसल को प्रॉपर्ली आइडेंटिफाई नहीं कर पाते, हम नर्व्स को आइडेंटिफाई नहीं कर पाते. सो इट गिव्स यू सच अ हाई प्रिसीजन सर्जरी कि आपके लिए सारी चीजें जो है ना, मतलब इट कैन work in a forward fashion, reverse fashion, upwards, downwards, and you can actually move your instruments wherever you want. But I'll show you, ये शायद आपको इतना मतलब बहुत अपील नहीं करेगा, but I'll show you another picture which is of a gallbladder surgery, and this is a very common surgery, तो शायद ये आप इसको ज़्यादा बेहतर तरीके से समझ सकेंगे. This is the gallbladder, and this is the same instrument which I am utilizing. On my right and left screens मुझे ये बताते रहते हैं कि मेरा कौन सा इंस्ट्रूमेंट काम कर रहा है और कितनी मैं एनर्जी उसके अंदर यूज कर रहा हूँ. ये जो आपको ये नजर आ दिस इज द हार्ट बीट. So this is the common bile duct, this is the liver, this is the gallbladder. I am first of all doing a posterior dissection, and you can see that normally जब हम open surgery करते हैं, laparoscopic surgery करते हैं, कभी हम जिंदगी में gallbladder को नीचे से जाके नहीं देख सकते. Never ever. So this gives us a view that wherever you want to go beneath an organ, in front of an organ, in top of an organ, in the lateral side of an organ, on the right side of the organ. You can just do. You can see that how versatile it is. You can just bend. जो भी आपने action करना है. I'm trying to locate the the cystic duct and the cystic artery, creating a space. Normally जब हमें सबसे बड़ी जो problem आती है जहाँ पे हमारी injuries होती थी, this is the area where you get this is the common bile duct. So this is the area where you tend to get these injuries. But this is such a high percent क्योंकि इसमें कोई गुंजाइश नहीं रहती कि आपको गलती खा सके. इसमें जो आपका जो आर्टिफिशियल इंटेलिजेंस इसके अंदर है वो आपको बताती रहती है कि आप कहाँ काम कर रहे हैं, आप किस ऑर्गन को टच कर रहे हैं, किस जगह पे आप जा रहे हैं, और इसने आपके लिए स्टेप्स मुकर्रर किए होते हैं. सपोज इफ आई हैव टू डू appendectomy, तो इसने स्टेप नंबर 1 2 3 4 5 6 7 8 9 10 डिटरमिन किया होता है. अब जब मैं जनरल सर्जरी कर रहा हूँ, लैप्रोस्कोपिक सर्जरी कर रहा हूँ, चूंकि मैं बहुत तजर्बाकार हूँ, 35 साल का तजर्बा है, तो मेरी होता है कि स्टेप नंबर 1 से मैं 3 पे जाता हूँ, 3 को मैं 5 पे, 5 से मैं 8वें पे जाके 10वें पे जाके काम खत्म कर देता हूँ, बिकॉज मैं बहुत तजर्बाकार हूँ. बट जिंदगी में अगर कभी कोई गलती होती है तो गलती तभी होती है जब कोई इंपॉर्टेंट स्टेप को आप जो ना आप खत्म कर जाते हैं उसमें से. सो दिस डज नॉट अलाउ यू टू डू इट. आपको स्टेप 1 से स्टेप 2 पे जाना है और स्टेप 2 से स्टेप 3 पे जाना है. अगर आप स्टेप 3 पे जाने से पहले स्टेप 2 को इग्नोर कर दिया, दिस विल गिव यू अ वार्निंग. अगर आप फिर भी कंटिन्यू करते हैं, दिस विल शट डाउन. वो कहेंगे आप इस काबिल ही नहीं कि आप ये ऑपरेशन कर सके. सो गो बैक टू नॉर्मल. So it is very important to understand that this artificial inbuilt intelligence not only makes it very easy, but it cautions you. It does not allow you to work without, without a guidance and without a supervision. So this is the cystic duct and this is the cystic artery. और मैंने जब ये रोबोटिक सर्जरी नहीं थी शुरू की तो मैं समझता था, मैं कहता था कि मैंने अपनी सारी जिंदगी किस मुश्किल में गुजार दी, ये कितना मुश्किल काम था जो मैं कर रहा था. एंड नाउ इट्स जस्ट लाइक जस्ट लाइक अ वीडियो गेम. बट अ वीडियो गेम जिसमें ऐसा नहीं है कि अगर आपको पसंद नहीं आए तो आपने खत्म करके दोबारा से शुरू कर दी. दिस इज अ वीडियो गेम वेयर यू रियली हैव टू बी वेरी वेरी प्रिसाइज. आपके पास सेकंड. सो आई मूव ऑन, ये तो लंबी हो जाएगी. तो बेसिकली जो रोबोटिक सर्जरी की ना कर्व्स हैं, लर्निंग कर्व्स हैं, कि पहले इनिशियल स्टेज ऑफ लर्निंग कर्व आती है जिसमें आपको बेंच ट्रेनिंग दी जाती है, जहाँ पे आपको जो है कंसोल पे बैठ के 15 डिफरेंट मॉड्यूल्स करने पड़ते हैं. जब मैं कैम्ब्रिज में इसकी ट्रेनिंग हासिल कर रहा था तो आपको पहले वो जो है ना आपको 15 जो है ना डिफरेंट मॉड्यूल्स करने पड़ते हैं, जो कि 1 महीने की ट्रेनिंग सिर्फ होती है. उसके बाद आपको जो है ना वो कैडावर्स पे लेके जाते हैं और उसके बाद ह्यूमन मॉडल्स के ऊपर लेके जाते हैं. और पहले आपको सिर्फ टेक्निकल कॉम्पिटेंसी आपको कहा जाता है कि आप छोटे छोटे लाइक लिम्फ नोड बायोप्सी कर लें, लाइक छोटा सा पेरिटोनियम का सैंपल ले लें. आपको कहते हैं कि छोटे छोटे प्रोसीजर्स करें और उसके बाद फिर आपको टेक्निकली डिमांडिंग. So this is step-wise learning, and the usual tenure is about 3 to 6 months. और वो देखते हैं कि प्रोफिशिएंसी जल्दी हासिल कर रहे हैं तो आपको 3 months में काम करने का मौका दे देते हैं. So the advantage is that you have got lesser operative time, lesser blood loss, length of hospital stay is reduced, and the complications are reduced. So definite ये study proven advantages हैं कि क्या क्या advantages हैं. So on every robotic console, this will be displayed. ये जो हमारा robot है, since it is a CMR robot, this is basically a robot manufactured by Cambridge. We have got a central server. So this data is displayed on all the central server of the Cambridge. इस वक्त दुनिया में तकरीबन कोई 287 robots Cambridge ने sell out किए हुए, उन तमाम का data जो है यहाँ पर जाता है उनका central data में. So this is my main dashboard. यहाँ पे आपका नाम आता है और उसमें आपकी जो total surgeries है, variety of surgeries, कितनी आपने किए, कितने मिनट हो चुके हैं आपको कंसोल सर्जन के तौर पे, ये काउंट होते हैं. जिस तरह आपने एयरफोर्स के या एरोप्लेन्स के पायलट्स को देखा होगा कि उनके जो है ना वो आवर्स कंसीडर होते हैं कि भाई इतने इनके फ्लाइंग आवर्स हैं, तो रोबोटिक सर्जन के भी ना रोबोटिक्स आवर्स कंसीडर होते हैं. सो एनीबडी हु हैज गॉट मोर देन 150 आवर्स ऑफ रोबोटिक सर्जरी एक्टिव कंसोल टाइम, जहाँ पे वो मॉनिटर आपको कर रहा होता है कि आप कितनी देर तक एक्चुअल बैठ के काम कर रहे हैं, so they are considered to be experts in robotic surgery. So I've crossed that benchmark. I'm now in 169 hours and 25 minutes. So gradually this will keep on improving. So this is the main dashboard. और whatever you do, everything is logged in. मतलब आप इस डेटा को concoct नहीं कर सकते, आप अपनी मर्जी से कोई रिसर्च प्रोड्यूस नहीं कर सकते, आप अपनी मर्जी से नहीं कह सकते मैंने 100 केस किया, मैंने 200 केस किया. This data is recorded by the computer. इसमें आपकी इनपुट कोई नहीं, आपको रोबोट नहीं पूछ रहा कि वो आपको, और रोबोट आपके लिए कर क्या रहा है, रोबोट आपकी एक एक चीज को नोट कर रहा है, रोबोट आपको यूज देख रहा है कि आपने
Professor Raza Ali Shah, Dr. Nasir Chaudhary, Dr. Irfan Muslim, and Dr. Salman Hamza.
Dr. Ikram, the most participant. Now I would like to Professor Dr. Mahmood Ayaz Sahab to present here. Mr. was our international guest speaker, though he is not here, and Dr. Shabana, she will come to. Mr. Wasim from Shadu Pharmaceutical. We are grateful to him for always supporting these academic activities. Our chairman department of ophthalmology, Professor Dr. Moin Jain, has written a state-of-the-art book regarding ROP. A very challenging topic indeed. I would like to request Professor Dr. Moin Jain to present his book to Professor Jalilul Dawla sir. Now I would like to invite Professor Asad Aslam Sahab for a vote of thanks.
Professor Jariq Sahab, Dr. Professor Moin, Professor Inzar Sahab, Professor Sajjad, Professor it's always a honor, privilege to have Professor Ajayullah among us. Professor, if I speak about him, you will not only probably miss the lunch, but the dinner as well. He is, I am lucky that I was born in an era which was governed by Professor Munir Sahab and Professor Ajayullah Sahab. Whereas Professor Munir Sahab was the pioneer of orbital surgery, Professor Ajayullah was the pioneer of vitreoretinal surgery at KE and Mayo Hospital. He was the pioneer of extracapsular with intraocular lens implant surgery in 1984 at KE and Mayo Hospital. Professor never had attendance in his lecture, but no student ever missed his lecture. For those who are newborn in ophthalmology, he is such a good teacher, he is such a pleasant personality, that if you sit with him over a cup of tea, you sit with him over lunch or dinner, you walk with him, you travel with him, he does nothing but he teaches. One day I was just coming down from Patiala block, from upstairs to downstairs, just to see him off to the car. And he taught me, even at that time, that myopes do not develop diabetic retinopathy. So this is just an example. He is such a pleasant and dedicated teacher. He knows the art of teaching. He knows the art of teaching. If you listen to his lectures, you will never forget. You will never have any urge to go to book and revise that lecture. That's a good teacher. Thank you very much, sir, for training us. We are grateful to Mr. Mahmood Ayasa, Vice Chancellor of the Medical University, for taking time out and delivering a wonderful lecture on robotic surgery. He is a surgeon at past, not known in the country, but abroad as well. So he is introducing new technologies in surgery to the resident, to the surgeon. Thank you very much for gracing the committee. We are grateful to OSP, President and Officer for using Mayo Hospital, Indiana Medical University as a venue for this clinical meeting. And this is probably the last meeting of this year. After this, from 8th to 10th December, we will be having ophthalmo, and then the clinical meeting will restart in year 2024. We are grateful to the company, I don't know which company, Shadow company, for Shadow company for supporting this clinical meeting. And last but not the least, we are grateful to Professor Munir Sahab, Professor Ahmed Mahmood Bhatt Sahab, Professor Ram Sahab, and all others who took time coming from other institutions to King Edward and Mayo Hospital and College of Ophthalmology, and all the faculty of ophthalmology of Unit 1, 2, 3, and College of Ophthalmology, and the postgraduate training for putting every effort to make this clinical meeting a success. Thank you very much.
Thank you very much, sir. Always patronizing us. आपको जिस चीज़ का इंतजार था वो दैट इज रेडी. अब हमारे जो टीचर्स हैं एट द स्टेज वो कॉन्फ्रेंस रूम में प्रोफेसर मोइन साहब ने उनके लिए अरेंजमेंट की है लंच के लिए, और बाकी आप सारे जो लोग हैं वो एलसीडी में जाएंगे. थैंक यू वेरी मच. जस्ट